Usually when we talk about a medical diagnosis, there's this expectation of precision, like engineering or something.
Right, yeah, like it should just be obvious.
Exactly. You break your arm, the X-ray shows that jagged white line, and the doctor just points and says, there it is.
It's binary. I mean, it's broken or not broken. You put a cast on it, and the path forward is just clean and obvious.
But then you step into the world of post-injection pain, and suddenly that X-ray machine is completely useless.
Oh, completely.
We're looking at a diagnostic landscape for you today in this deep dive that is, well, honestly, it's incredibly murky.
Yeah.
Because when a patient gets a medical injection, say like an epidural steroid for back pain, or maybe a nerve block, and they come back days later in severe escalating agony, clinicians are facing this terrifyingly high-stakes puzzle.
They really are.
They have to evaluate whether that persistent pain is just, transient nerve hyperalgesia, which is basically just a highly sensitive, irritated nerve, versus a dangerous tissue-destroying secondary infection.
And I mean, it sounds like a straightforward distinction on paper, right? Like an angry nerve on one side, a bacterial invader on the other.
Right. You'd think they'd look totally different.
You would, but the reality is that a sterile, completely bacteria-free inflammatory reaction can perfectly mimic a severe infection.
Wow.
Yeah. The skin gets red, it swells, it radiates heat, it throbs. Everything looks the same from the outside. So understanding how doctors actually solve this diagnostic mystery, it reveals these incredible insights into how our nervous and immune systems interact.
And what happens when they completely misfire, I imagine?
Exactly, when the whole system just goes rogue.
So to start this deep dive, before clinicians can even begin to identify a dangerous complication, they first have to establish what a normal post-injection reaction actually looks like, right? Yeah. We have to set the baseline here. Because needles just inherently cause trauma.
Yeah, you can't spot the anomaly until you define the expected standard. And the standard is that, well, you are taking a sharp piece of metal and pushing it through the body's barriers.
Right, it's an injury.
It is. Even if a practitioner is just doing like dry needling with no medication at all, or injecting something completely inert like simple saline, that mechanical trauma alone provokes pain and inflammation.
Because it's tearing things up on the way in.
Exactly. The needle is physically shearing through sensitive fascia, muscle tissue, and, microscopic blood vessels.
But the reaction gets profoundly more intense when you introduce actual medications, specifically steroid injections, right? It's not just the needle anymore.
No, not at all. The physical location of that steroid injection matters immensely here. When a steroid is placed in a tight perineural space...
And that's the space right around the nerve.
Yeah, that microscopic real estate immediately surrounding a nerve root. When you put a steroid there, it triggers a massive cascading physiological event. First, you have this transient crystal-induced inflammation.
Okay, wait, let's pause on that because mechanics here are fascinating to me.
Yeah.
Why does the steroid itself cause inflammation when it's literally supposed to be an anti-inflammatory drug?
It's super counterintuitive, I know. But it comes down to how the drug is formulated. Many injectable steroids are crystalline suspensions. So you are physically depositing these tiny microscopic crystals right next to the nerve.
Oh, okay.
And the body's immune system, specifically these cells called macrophages, they constantly patrol the area. They see these crystals and recognize them as foreign debris.
Like dirt in a wound or something?
Exactly. So the macrophages attempt to eat the crystals to clear them away, but the thing is they can't digest them.
Oh, wow.
Yeah, so the macrophages essentially gorge themselves, fail to break down the crystals, and they just burst, which releases this massive wave of inflammatory alarm signals right onto the nerve.
So you get this intense chemical fire before the drug even starts doing its actual job? That's wild. And plus, there is just the physical reality of putting fluid where there wasn't fluid before, right?
Yeah, you get profound pressure effects. You're forcing a volume of liquid into a completely confined space, which obviously stretches the tissues and physically compresses the nerve.
Right.
And on top of that, these injections often cause local vasoconstriction. So the microscopic blood vessels that actually feed the nerve, they clamp down.
Which means the nerve is basically temporarily starved of oxygen.
Precisely. And that oxygen starvation creates a deep, suffocating ache. So when you combine the burst macrophages, the fluid pressure, and the temporary lack of oxygen...
It's a perfect storm.
It really is. You get a very distinct, highly expected timeline for a standard flare. It usually begins within hours of the procedure. It hits its absolute peak within about 24 to 48 hours, and then it gradually, reliably improves.
Okay, so the character of that normal pain is usually described as a deep, somatic, bruised, or stiff feeling, right? Heavily localized to the exact spot where the needle went in.
Yeah, exactly.
I tend to think of this as the stub toe effect.
The stub toe effect.
Yeah, like you stub your toe, and the pain is blindingly intense right away. It swells up, it throbs, it turns bright red. But you know implicitly that tomorrow it'll hurt a little less, and the day after that even less. It follows a highly predictable downward curve of healing.
That's a really great analogy. The normal inflammatory flare is a closed loop of inflammation, just like the stub toe. The immune system rushes in, does its messy job, and then packs up and leaves.
Right.
But the diagnostic puzzle really begins when the pain fails to follow that downward trajectory.
So, like, what if it plateaus?
Hmm.
Or worse, what if a week later it's actually amplifying?
Right. If the pain doesn't follow that downward curve, clinicians have to immediately pivot their thinking. They transition from evaluating simple mechanical tissue trauma to evaluating the really complex rewiring of the nervous system.
So they have to look at whether the nerve itself has become hypersensitized.
Exactly.
Which brings us to a foundational concept in the clinical literature for you guys listening, which is hyperalgesia. By definition, this is an extreme, wildly out of proportion reaction to painful stimuli. Like when a nerve stays angry, it doesn't just hurt, it actually changes how it perceives the physical world.
Yeah, a prime example is something called postneurotomy neuritis, or PNN. This can develop after procedures like radiofrequency ablation, where a nerve is intentionally heated to stop pain signals.
Okay.
The resulting pain is completely different from a standard inflammatory flare. Like you said, a flare is that deep, bruised ache. But PNN is a purely neuropathic state.
Meaning nerve pain.
Right. Patients describe sensations like burning acid, or electric shocks shooting down their limbs, or just a constant pins and needles tingling.
And most notably, they develop allodynia,
Wow.
which is pain from a stimulus that shouldn't register as pain at all, right?
Yes. To understand allodynia, just imagine putting on a normal cotton t-shirt, or taking a warm shower, or just feeling a gentle breeze from an open window.
Sounds nice.
To a healthy nerve, those are neutral or even pleasant sensations. But to a nerve experiencing allodynia, the light brushing of that cotton fabric registers in the brain as dragging a blowtorch across the skin.
That is horrifying.
It is. The system is amplifying a whisper into a deafening scream. And unlike the stub toe, PNN plateaus, or even worsens, long after the initial procedure.
And there is a specific, highly paradoxical form of this that affects up to 30% of individuals who rely on opioids to treat chronic pain, right? It's called opioid-induced hyperalgesia, or OIH.
Yeah, OIH.
The very drugs manufactured to stop pain are actually lowering the patient's pain threshold, making them more sensitive to everything.
It creates a devastating cycle in pain management known as the escalation trap. A patient's back pain gets worse, so the well-meaning doctor increases the opioid dose.
Literally.
Right. And the higher dose provides relief for maybe a week or two, but then the pain returns, surging even higher than before. Worse, it often spreads. A patient who only had lower back pain suddenly reports agonizing pain in their shoulders or down their legs.
Okay, I have to ask about this. If opioids are fundamentally designed at a molecular level to block pain signals from reaching the brain, how exactly does this neuroplasticity trick the brain into amplifying the pain instead?
It comes down to central sensitization. The human nervous system is incredibly adaptable. When you introduce chronic opioid exposure, the brain notices that its pain signals are being artificially muted.
Okay.
So in an attempt to maintain homeostasis, it fights back. It activates a specific set of receptors in the central nervous system called NMDA receptors.
And what is the normal day-to-day function of an NMDA receptor? Like, what are they supposed to do?
Normally, they act as an amplifier for pain signals when you suffer a really severe injury, just to ensure you protect the wound and survive.
Like telling you, hey, don't walk on that broken leg.
Exactly. But opioids, over time, cause these NMDA receptors to become permanently stuck in the open position.
Oh, no.
Yeah. And on top of that, as your liver breaks down the opioid, it creates toxic metabolic byproducts like morphine-3 glucuronide. These metabolites act as direct neurotoxins, further agitating the central nervous system.
So the neuroplasticity that usually helps us learn and adapt and heal, it just gets entirely hijacked. The brain locks itself into a state of maximum threat detection.
It really does. And the rewiring isn't just chemical either. It can be wildly physical.
What do you mean?
Well, following a peripheral nerve injury, say, from a needle or a chemical injection, the body can undergo aberrant reinnervation, We have sympathetic nerve fibers, which are responsible for your fight or flight response. They control things like sweating and heart rate.
Right.
After an injury, these sympathetic fibers can physically sprout and grow into sensory areas of the skin where they absolutely do not belong. They crosswire with the pain pathways, driving a persistent neuropathic fire that has absolutely nothing to do with the original injection.
So the body is literally growing new microscopic wiring that just broadcasts the constant distress signal.
Exactly.
Wow. Okay, so hyperalgesia gives us a really clear mechanistic explanation for prolonged, strange, burning nerve pain. But the clinician's job isn't done because they have to rule out the darkest possible outcome.
They do.
What if that prolonged pain isn't just a miswired nerve? What if it is a ticking time bomb, like a rapidly multiplying bacterial infection deep in the spine?
Right. This is where the evaluation turns into a really high-stakes investigation. A clinician can afford to take time to manage hyperalgesia. They absolutely cannot afford to miss a secondary infection because the window to prevent permanent paralysis or death can close very fast.
Yeah, looking at the data, acute spinal infections following these procedures are thankfully very rare. We're talking about an incidence rate of roughly 1 in 1,000 to 1 in 10,000 procedures. But when they do occur, they are catastrophic.
Oh, totally catastrophic.
We're talking epidural abscesses, meningitis, or spondylodiscitis, which is a severe infection eating into the intervertebral discs and the actual bone of the spine itself.
Yeah, and distinguishing these rare catastrophes from a common flare, it really comes back to timing and trajectory. Like we said, a sterile flare peaks early, usually within 48 hours, and then drops off.
Right, the stub toe.
Exactly. But an infection often incubates during those first few days and then progressively worsens well beyond that critical 72 to 96-hour mark.
Though I noticed there is a massive, terrifying exception to that timing rule in the clinical data.
You're talking about Streptococcus pyogenes cellulitis.
Yes, exactly.
Yeah, while most pathogens take days to build an army, strep pyogenes can evolve incredibly rapidly. It can become extensive and life-threatening within just 12 to 24 hours of the injection.
That is terrifying.
It is. But for the vast majority of other pathogens, the evolution is a slow, steady march over several days.
So to catch these infections, clinicians don't just stare at the injection site, right? They rely on systemic criteria to look for red flags across the entire body.
Yeah, they are looking for the body's alarm bells. A significant fever is a major indicator. They run blood work to look for massive spikes in white blood cells. Essentially, the body's infantry multiplying to fight an active war.
Makes sense.
They also look for massive elevations in C-reactive protein, which is the liver signaling widespread systemic inflammation. And of course, they look for continuous, purulent drainage pus leaking from the puncture site.
And the character of the pain itself changes, too. An infection causes a progressive restriction of movement, severe functional deterioration, and, this seems to be the most critical red flag, neurological deficits.
Yeah. A sterile flare hurts, but the nerve still functions. If a patient suddenly has a new foot drop, or they've lost their deep tendon reflexes, or they can no longer feel the vibration of a tuning fork on their ankle,
That's bad.
that strongly points away from simple inflammation. It points toward a physical mass of pus or an abscess expanding in a closed space and physically crushing the nerve pathways.
Okay, but this raises a massive practical dilemma. Let's put ourselves in the clinic for a second. On day 2, a normal, intense steroid flare causes warmth, redness, and swelling at the injection site.
Right.
But an early bacterial infection also causes warmth, redness, and swelling at the injection site.
Right.
So how does a doctor realistically tell the difference between a sterile inflammatory reaction and a dangerous bacterial infection on day 2 when the outward symptoms are utterly identical?
That dilemma is the exact reason clinicians use a highly disciplined 4-part evaluation framework. They can't rely on just one symptom, so they evaluate the entire clinical picture to find the pattern.
Okay, walk us through that narrative. A patient comes back on day 4. Their lower back is throbbing. The skin is angry and red. How is the doctor processing this?
Well, the very first thing the doctor looks at isn't the swelling, it's the clock, the timing.
Okay.
Did this pain hit like a freight train 3 hours after the injection, which points to mechanical trauma or a steroid crystal flare? Or did the patient feel mostly fine for 3 days and only now is the pain starting to ramp up, suggesting an incubation period for bacteria?
Right. Then they look at the trend line, the trajectory.
Exactly. Is it getting better or worse? The stub toe always feels better on day 4 than on day 1. If the patient says, "Doc, yesterday was bad, but today is unbearable," That escalating trajectory is a major warning sign.
Next, they pan out, right? And look at the rest of the body for associated symptoms.
A sterile flare leaves you feeling generally fine, just locally in pain. An infection makes you feel systemically sick. Are you shivering? Are you running a fever? Are you profoundly fatigued?
Check the whole system.
Right. And finally, they analyze the pain pattern itself. Is this the same familiar backache you originally came in to get treated, just amplified? Or is this a bizarre, new, burning sensation shooting down a leg that never hurt before?
But I mean, even with that detailed matrix, sometimes the clinical exam just isn't enough to break the tie, right? The waters are still too muddy. That's when they have to look beneath the skin using advanced imaging.
Yeah, magnetic resonance imaging, or MRI, is the gold standard here. But radiologists aren't just looking for a blurry gray spot of swelling. They are looking for highly specific physical signatures, specifically something called T2 hyperintensity combined with focal diffusion restriction.
Wait, what does focal diffusion restriction actually mean for the tissues inside the patient? Like practically?
So it's a way of measuring how freely water molecules are moving deep inside the tissue. In simple, sterile swelling, like from a steroid flare, water moves around pretty freely through the tissue planes.
Okay.
The MRI sees that free movement. But purulent collections, which is just pus, are totally different. Pus is incredibly thick, highly viscous, and packed tightly with millions of dead immune cells, dead tissue, and bacteria.
Gross, but okay.
Yeah, so the water molecules get totally trapped in that sludge. Their movement is restricted. So if the MRI shows restricted diffusion, the radiologist knows they are looking at a dangerous, pus-filled abscess, not just sterile fluid.
That is such an incredible use of physics to solve a biological problem.
It really is.
And clinicians also use high-resolution ultrasonography. There's a fascinating case study in the literature involving an intraneural ulnar nerve abscess caused by lepromatous Hansen disease, which is better known as leprosy.
Oh, yeah.
Now, obviously, leprosy isn't something most people associate with a routine spine injection. But researchers use this case as a masterclass to illustrate exactly how clinicians view the internal architecture of a nerve under ultrasound when an abscess actually forms inside it.
It's a perfect illustrative model because of how aggressively leprosy attacks peripheral nerves. When a clinician puts an ultrasound probe over a healthy, normal nerve, it has a very distinct, beautiful honeycomb appearance on a transverse scan.
Honeycomb.
Yeah, you can literally see the individual nerve fascicles packed neatly together, surrounded by connective tissue.
It looks exactly like a cross-section of a fiber optic cable, basically.
Yeah.
You have all those tiny individual glass threads bundled perfectly and neatly inside the main plastic casing. Highly organized, meant to transmit data efficiently.
And if we take that fiber optic analogy a step further, an infection essentially melts the internal plastic casing.
Oh, wow.
Yeah. When an abscess forms inside that nerve, that neat honeycomb bundle is utterly destroyed. On the ultrasound, clinicians see what's called fusiform enlargement.
What did that look like?
The nerve just swells up and bulges out like a spindle. There is a complete, devastating loss of that healthy honeycomb architecture.
So the organized fiber optic cable just turns into a disorganized, swollen, chaotic mess.
Exactly. The ultrasound also reveals intraneural hypoechoic foci, which are these dark, fluid-filled pockets of pus forming right inside the nerve casing. And when the clinician turns on the color Doppler, which measures active blood flow, the screen just lights up.
Really?
Yeah, they see massively increased vascularity. A healthy nerve shouldn't have internal rushing blood flow like that.
So by combining the clinical matrix, checking the timing, trajectory, systemic symptoms, and the pain flavor, along with physically peering at the architectural integrity of the nerve using MRI, water diffusion, and ultrasound honeycombs, they finally solve the mystery. They can actually separate the angry, hypersensitized nerve from the flesh-eating pathogen.
It is a phenomenal application of deduction and technology. Evaluating post-injection pain isn't just about asking a patient to rate their pain on a scale of 1 to 10. It is entirely about recognizing the pattern of the pain and the underlying mechanics driving it.
And recognizing these patterns empowers clinicians to avoid the escalation trap of just throwing more opioids at a miswired nerve and to catch dangerous compressive infections before they cause permanent paralysis.
It's all about matching the right biological mechanism to the right clinical response.
But before we wrap up, I want to leave you with a final provocative thought regarding systemic inflammation to mull over. Recent immunological studies show that our body's own pro-inflammatory cytokines, specifically markers like IL-1 beta and IL-6, which are the chemical signals that trigger the healing process peak at the exact same time that neuropathic pain develops after a nerve injury.
It really forces us to question our basic assumptions about healing and disease. I mean, inflammation is the body's fundamental defense mechanism. It's how we clear away dead tissue and initiate repair.
Right. So if our immune system's standard healing response, those very cytokines meant to fix the needle damage, perfectly mirrors the onset of chronic neuropathic pain, could our own aggressive attempt to heal a simple wound be the very mechanism that accidentally locks us into long-term hyperalgesia,
Wow.
even when there is absolutely zero infection present?
So the very process designed to save the tissue might be the exact trigger that permanently rewires the nervous system to feel chronic pain.
It brings us right back to the beginning. We want the medical x-ray to show a clean break, a simple cause and effect where we can just apply a cast and move on. But in the world of nerves and inflammation, the lines blur entirely. Sometimes the body's response to the trauma becomes the disease itself, and that x-ray machine is left completely useless in the muddy waters of the human nervous system. Keep questioning, keep learning, and we'll catch you on the next deep dive.